The Ottawa ankle rules state that radiographs are indicated if there is pain in the malleolar zone and if any of the following criteria are met. Tenderness along the tip of the posterior edge of the distal 6 centimeters of the lateral malleolus. Tenderness along the medial malleolus. Or an inability to bear weight for 4 steps. The Ottawa ankle rules also state that radiographs are indicated if there is pain in the midfoot area and any of the following criteria are met. Tenderness at the base of the 5th metatarsal. Tenderness over the navicular. Or an inability to bear weight for 4 steps. The test item cluster for patients who would respond to spinal stabilization includes an age less than 40 years old, average passive straight leg raise greater than 91 degrees, aberrant movement are present, and a positive prone instability test. A straight leg raise is performed with the patient lying supine with hips in neutral and knees fully extended. The therapist will raise the lower extremity into hip flexion while maintaining knee extension and measure the angle of the hip at end range. Aberrant motions can consist of an instability catch, painful arc of motion, thigh climbing or a pseudo-Gower sign, or a reversal of lumbopelvic rhythm. The prone instability test is completed with the patient lying prone with the body on the examining table and the legs over the edge resting on the floor. The therapist applies pressure to the posterior aspect of the lumbar spine while the patient rests in this position. The patient then lifts the legs off the floor and the therapist again applies posterior compression to the lumbar spine. If pain is elicited in the resting position only, the test is positive because the muscle action masks the instability. The test item cluster for patients who would respond to spinal manipulation includes a duration of symptoms of less than 16 days, no symptoms distal to the knee, lumbar hypomobility, at least one hip with greater than 35 degrees of internal rotation, and a fear avoidance beliefs questionnaire score of less than 19 on the work subscale. Segmental mobility of the lumbar spine is tested with the patient prone and the neck in a neutral position. The therapist stands at the side of the table and places the hypothenar eminence of the hand over the spinous process of the segment to be tested. With the elbow and wrist extended, the therapist applies a gentle but firm anteriorly directed pressure on the spinous process. The stiffness at each segment is judged as normal, hypomobile, or hypermobile. Hip internal rotation greater than 35 degrees. The McMurray test. For this test, the patient is supine. The therapist grasps the ankle of the tested limb with one hand. The other hand is placed on the tested knee with the thumb over the lateral joint line and the middle finger over the medial joint line. The knee is maximally flexed, externally rotated, and slowly extended to assess the medial meniscus. The knee is maximally flexed, internally rotated, and slowly extended to evaluate the lateral meniscus. A positive test is indicated by a palpable or audible thud or click when performing this test. The Lockman test. This test is performed with the patient lying supine with the involved leg on the side of the examiner. The femur is stabilized with one hand with the patient's knee in 20 to 30 degrees of flexion. The therapist's other hand is applied to the posterior aspect of the proximal tibia. An anteriorly directed force is applied to displace the tibia. Increased anterior tibial translation with a soft end feel compared to the contralateral side constitutes a positive test indicating disruption of the ACL. The straight leg raise test. The patient is lying supine with their lower extremities relaxed. The therapist elevates the leg into 30 degrees of hip flexion with the knee fully extended. Positive test occurs when the patient experiences radicular pain going down their leg. The test item cluster for patients with hip osteoarthritis includes self-reported pain of squatting, diminished passive internal hip rotation, less than or equal to 25 degrees, pain with hip flexion, pain in the inner quadrants during the Scour test, and pain with hip extension. Passive hip internal rotation less than or equal to 25 degrees. The scour test. Patient is supine. Examiner fully flexes and adducts the involved hip until resistance is felt. Maintaining full flexion, the therapist slowly abducts the patient's limb until full range is reached. A positive test occurs if this recreates the patient's pain. If there is no pain, the therapist performs the same initial motion, but then applies an axial load through the femur during abduction. A positive test occurs if this recreates the pain. Posterior drawer test. For this test, the patient is supine with the knee flexed to 90 degrees. The therapist sits on the patient's foot and applies the thenar eminence of both hands on the anterior aspect of the proximal tibia. A posteriorly directed force is applied to displace the tibia. Increased posterior tibial translation with a soft end field compared to the contralateral side constitutes a positive test indicating disruption of the PCL. Posterior sag test. For this test, the patient is supine. The therapist holds the heels of both feet and flexes the knees and hips to 90 degrees. The position of the proximal tibia of the involved limb is compared to the contralateral limb. The position of the proximal tibia of the involved limb is set more posterior relative to the femoral condyles as compared to the opposite side. The test is positive, suggesting disruption of the PCL. The differential diagnosis for an L5 radiculopathy versus gluteal and hamstring weakness. An L5 radiculopathy will present with weakness primarily in the extensor hallucis longus muscle, as well as with impaired sensation of the lateral aspect of the lower leg and middle of the dorsum of the foot. Weakness will also present in the gastrocnemius, soleus, and hamstrings. Radiculopathy can be tested with a straight leg raise test, well leg test, or with repeated motions into a directional preference looking for centralization of pain. Gluteal and hamstring weakness will present as weakness during manual muscle testing and will not show centralization of pain during repeated motions into a directional preference. Sensation will not be impaired with weakness in these muscles. A well leg test will be performed the same way as a straight leg raise test by raising the lower extremity into 30 degrees of hip flexion. For a positive test with this test, you're looking for symptoms going down the contralateral limb.